Alrighty, it is 9:45. So we're gonna get started. Unmuted, I'm share screen. I think I got everything going. All right, well, good morning. It's kind of hard to believe that it's only been 1 week of head and neck, isn't it? For me too, I really enjoy it. I thought I'd go along with all your lectures this year. So every other year I try to watch all of them so I can not forget things like little tiny branches of nerves. And so I'm happy today to be given a large amount of information to deliver to you in a short amount of time because I like challenges. And so we are going to talk about some regions that you will dissect, some of which you've already seen. And then some regions you're going to dissect in depth next week. And then we're going to talk about one region that you're not really going to dissect, but I'm going to give you the skinny on what you need to know about that as a clinician. So just in case you do go into any fields where it becomes relevant, you will have a wonderful baseline knowledge. Okay. So the first area that we'll talk about today, and this is the simplest one, is the temporal fossa. And you've already been introduced to the temporal fossa by Dr. Nodcott and Dr. Tubbs. They've talked to you about the bones that make up the temporal fossa, so make up this floor. And so that's what you see here on this list on the side. These are the bone marks, so like the supramasstoid crest you can see here, superior temporal line. So these are just borders. I don't expect you to memorize borders of every single region, but if you're holding your skull, you can look at that area and understand by looking at the borders where the temporal region is. It will be filled up, and I know Dr. Tubbs already talked to you about the pterion and the importance of it being in close approximation to the middle meningeal artery on the other side. If you look at the other side, the soft tissues that are included in the temporal fossa, you just were introduced to this muscle in the last lab. It was on your list called the temporalis muscle. And that is included and it fills up the temporal fossa. And so we'll get a chance to reflect this muscle in the next lab. And you'll really get to see it in all its glory. You'll take off the temporal fascia and you can see all of its muscle fibers. And you may have feel tension in your temporalis muscles sometimes on the side of your head and get headaches from that and clench your jaw. And that's because it does have an action on the jaw, which we'll talk about. But more realistic is the picture here on the right side. You can see all of the other soft tissue structures that are included. So the zygomatic arch here. If you go superior to that, this is the temporal fossa. And so the superficial temporal vessels, also the great auricular nerve, we've been introduced to those already. So those are contents that are in this region. Like I said, this is the lightest region that we'll talk about. And we're done. So that's the temporal fossa. You'll look at it again in lab, and now you'll have a little renewed sort of excitement and motivation to point out the temporalis muscle. Now, this next area is super fun, not only because you will find probably all of the structures that we're about to talk about. You can find them. I know I have faith in you. We all have faith in you, and they're pretty easy to get to. But in addition to that, I forgot what the second thing was I was going to say. So I'm just going to go to the next slide, and it'll come to me. Okay. And so what was it? So you'll get to dissect it was cool. Oh, and that it is a very famous nerve that has been brought up by Dr. Nodcott and Dr. Tubbs. So V3, and actually Dr. Lawson just talked about it briefly too. So you've heard V3, 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 and muscles of mastication. In the development session yesterday, we talked about the first pharyngeal arch. And the muscles that are derived from that. All of this will come together when we dissect this region. And so the infratemporal fossa, as the name leads you to believe, is inferior to this temporal fossa, but it's not just inferior, it's also deeper than that. So here you see the side of the skull here, and you can see that the mandible has been removed. And we've also cut off the zygomatic arch. And yes, we will be doing that in lab so that you can get down into this infratemporal fossa region. You can see the posterior aspect of the maxilla is a main player, being the anterior border here. You can see that the greater wing of the sphenoid bone is going to be a huge player in regards to being the roof. And then you have these special processes that stick out that are actually part of the sphenoid called pterygoid plates. And the good news is that muscles that attach to those plates are also have the word pterygoid in them, which is helpful. And you want to make sure that you take a look at the skull. And you can do that either this weekend where you're reviewing material, or you can wait and we can do it all together in lab. And so those are the main players that this is the main area that you'll be looking at next week. Okay. So what was in this space? So now you can kind of understand where the space is located at, but what is in there? Why do we care about it? Well, the mandibular nerve of the trigeminal, so V3, fills up the space. So we have lots of branches. The good news is that most of them are pretty hardy. So you're not just gonna, just snip them right off, taking out the fascia and fat. So you'll get a chance to see all of these, whether you have them all on your cadaver or put everybody together. But we're gonna help you out. The other structures that are in this infratemporal fossa are the muscles. So you can see these muscle bellies that are kind of filling up the infratemporal fossa. So not only do we have the temporalis muscle that is sort of on the outer part of the temporal fossa and coming down and inserting on the mandible, we also had a masseter muscle that was removed. And as you look inside the infratemporal fossa, you can see that we have more muscles. And as you move into a little bit anterior, you may have also started to peek at a muscle called the buccinator in the cheek. And I will clue you into why that muscle is special and is kind of set apart from these other muscles in regards to innervation. And then there is a ligament that's not pictured on this slide, but I will bring it up again and show you an image that has the ligament depicted, called the sphenomandibular ligament. And this is not a small little ligament. This is a decent sized ligament that you will see, and you'll have to remove it to be able to get into the infratemporal fossa. So all of this really fun stuff we will get to view. Now, that's cool, and this is what your dissection will look like, but this is what you're going to start with. So you're going to have a dense venous plexus, this pterygoid venous plexus, that will be in the infratemporal fossa. It's kind of frustrating to dissect if you don't remove. I remove a lot of the veins so that I can see the nerves and the muscles and the arteries that I'm looking for. But clinically, Dr. Nodcott and Dr. Tubbs both mentioned the clinical application of this venous plexus because it allows communication, and I have an additional slide, between a vein that's in the face, a vasal vein, and also the cavernous sinus. So it has two different routes that bacteria that gets in the veins can actually make its way to the cavernous sinus and cause a thrombosis. Okay, so these muscles of mastication, you've been introduced to, so I know I'm not the first person to talk to you about them, but I have a guide here for you to follow. All these muscles have in common that they're innervated by V3. They act upon the jaw to help you chew. Now, are they all of the muscles that are innervated by V3? No, because you learned yesterday that pharyngeal arch 1, all of the muscles included these 4, but also had 2, right? The mylohyoid and the anterior belly, the digastric, are also included in the pharyngeal arch 1. And so although we very commonly say, oh, V1, muscle of mastication, don't forget those 2 muscles that are included. But these 4 do actually act upon the jaw. So here you can see the temporalis muscle. It is attached here to the coronoid process of the mandible. So you can imagine what these fibers would do as they contract and pull on the mandible and elevate it. And then the directional difference of the fibers that are more posterior would have a different action. And that is true. We'll go over that. And then you can see that it's been removed on this picture, but if you move to this figure over here, that there is a muscle that is on the external aspect of the mandible going down to the angle and coming up to the zygomatic arch, and that's the masseter muscle. You may or may not have run into that yesterday when we dissected the face. I had several people say, what is this, these big muscle fibers here? Well, that's the masseter muscle. And in the next lab, you'll be isolating the masseter muscle, cleaning off its anterior and posterior border so that we can reflect it downwards, cut the zygomatic arch, and approach the infratemporal fossa. So you will all get a chance to really understand the masseter muscle as well. And then we have two other muscles. Both muscles have two heads, so they have two different places of origination. Do you need to know which head has which? Not necessarily, but the origination of the muscles are kind of all in the same sagittal line. So know the bone that it comes from, the general region. And if you take a time to look with your skull at these bone marks that are a little more obscure that we haven't gone over necessarily and may not be on the structure list, it will still help you orient yourself to this infratemporal fossa in relation to another area like the pharynx, the nasopharynx, and that region. Remember, when you're holding the skull, there's a lot of soft tissues that are missing and that help separate your body into different compartments. And why that's important for you is because of bleeding, and because of infections, and because of tumors. So Osmosis also has some cute little videos, and I thought since it's Friday, we have a lot of material to get through, I would throw in some happy colors in the figures as well. So I did put these figures in here, and it gives you just the deets on every one of these muscles if you want a very quick study guide. And you can hold your skull and you can look at the origination and insertions. I know that Dr. Anadkat was telling you the other day, he's not going to drill you on actions, because you can think about, if you know where the muscle comes from and where it goes, if those fibers were to contract, you can kind of put it together what their main actions are. And I think that that's fair. So here we have the temporalis muscle that I talked about. So the temporalis here, which acts in unison with the masseter. So you have the masseter muscle here. And then the pterygoid muscles are slightly more complex because they both have two heads, so that you can see that I'm not going to ask you the different origination of the deep head versus superficial, but I do expect you to hold a skull and know where the medial pterygoid muscle comes from. The good news is I said that lateral pterygoid plate was going to be important, that bone mark of the sphenoid bone, and it is important for both of these pterygoid muscles because they both have part of their origination on that lateral pterygoid plate. And if that's the only thing you remember about the pterygoid muscles origination, you know, I would still be pretty darn happy about that. So the lateral pterygoid plate has two sides. It has a lateral side and it has a medial side. And the lateral pterygoid muscle originates in part from the lateral side, and the medial pterygoid muscle does originate in part from the medial side of that lateral pterygoid plate, okay? And then their insertions are very different. So if you look on this list here, it says that the medial pterygoid, which is this muscle here, you note that the fibers are running more up and down and less horizontal. So they're more vertical and less horizontal than the lateral pterygoid. And actually, when we looked at this figure here, and you note that the masseter on the outside of the mandible's fiber orientation was very similar to the fiber orientation of the medial pterygoid, it just was going in a slightly different direction. So they kind of have a sling on the mandible, one on the outside, the masseter, and one on the inside, the medial pterygoid. So M, they both start with M. That also might help you remember which one is which. And they both have separate branches, muscular branches from V3 that are going to innervate them. The lateral pterygoid, though, does not come down and insert on the angle of the mandible. You note that the lateral pterygoid muscle actually comes over here to the neck and the auricular capsule and the auricular disc of the TMJ joint. And so that actually allows the lateral pterygoid to have a different action and also play a different role in regards to changing the motion of the TMJ joint. Okay, so those muscles, as they look like, they're small and they're really deep inside, you will find them. We will see them. Some of you may be aggravated by them because they might be big and in your way, but I promise at the end of the day, you're going to be happy you know them. Well, that might have been a stretch, but you know what I mean. Okay. The lateral and medial pterygoid muscles, all of the muscles besides temporalis do help with protrusion, but lateral and medial pterygoid muscles are very important for side-to-side motions of chewing as well. And the lateral pterygoid also helps with depression. So I'm going to point that out because it's very different from the other muscle actions, the only one that helps with depressing the mandible. And we'll talk about the TMJ joint in a second, but you just might want to note that the lateral pterygoid, because of how it attaches here to the head of the mandible, can actually help depress the mandible open. The main action for depression was just gravity. We don't have a muscle that just really depresses the mandible, but lateral pterygoid can assist. Okay, I like this cool view. You're not really going to see this in dissection, but it's looking forward at the pterygoid muscles and seeing how they crisscross. So the medial pterygoid coming from the medial side of the lateral pterygoid plate, and then coming and inserting here on the angle of the mandible. In contrast to this lateral pterygoid, which is coming from the lateral side of the pterygoid plate. I know I'm oversimplifying their origin, but coming over and inserting on the head and neck of the mandible. Condyloid process. All right. Now, I said I'd come back to the buccinator because it's kind of a cool, different, it's got something different about it. Well, that's because the buccinator is a muscle of facial expression, not a muscle of mastication. So although it does line the cheeks, right? In this image here, this was from a paper I found at like 3 in the morning where they were looking at jazz musician, trumpet players, and they were looking at the changes of musculature as they trained to, blow air forcibly through a trumpet. And I just I've never seen that view before, so I had to drop that in. So here you can see the buccinator muscles here on the sides and how it would help a person expel air forcibly through their mouth to play a trumpet. Pretty cool. So I just want to make it something different that you remember, because the buccinator muscle is not, even though it will be right there, it's right there in the area that you're going to be in. And to boot, there's a nerve called the buccal nerve. That's a V3 branch. Does not innervate this muscle. This muscle is a muscle of facial expression, so is innervated by cranial nerve 7. Yes, question?
Could you just point out the the pterygoid plate? I'm a little confused if it's deep or if it's like more superficial.
The pterygoid plate?
Yeah.
Yeah, the muscles.
Image in the previous image, I'm just a bit like.
On this image?
That image, and then because it looks deep on this image and then more superficial on the other.
Yeah, because it is deep on this image. Here's the mandible that is still intact. And so you'd have to cut the mandible off to look directly at the lateral pterygoid plate. And I have more images of this later on. And I think one of my earlier images had it cut off. So this is the lateral pterygoid plate right here. The mandible is cut off, and that is how you would be looking directly at the lateral pterygoid plate, which is a part of the sphenoid bone. Okay? Yes. Okay. So, branches of the mandibular nerve. These are the cool branches we're going to find. You're going to know them by heart. You're going to love them. So, these nerves are sensory nerves that are bringing sensation back mostly, okay? And also muscle branches that are going to those muscles we just talked about. And that's why V3 has a muscular component. So, I think we're going to go one by one. Though the biggest one that you will find, and it will be the most superficial when you're cutting the mandible, is called the inferior alveolar nerve. This nerve you can sometimes sever when you cut the mandible, but we're all here at Tulane, so we're not going to sever the inferior alveolar nerve. But if you do, super glue works great to put it back together. So the inferior alveolar nerve will enter the mandible and then will course anteriorly, and it gives off this inferior dental plexus and terminates as the mental nerve. And yesterday in lab, we found the mental nerve. That was part of one of the goals, right? We found that we had V1, we had V2, we had V3. That's the V3 that you found yesterday. Well, we're going to find the rest of it next lab. So that nerve is hard to miss. There's also arteries that artery and vein that runs with it. And I do not have a separate slide. I forgot I took off my highlight. It's interesting to note that the nerve to the mylohyoid muscle, which this nerve also supplies the anterior belly of the digastric muscle, will come off of this inferior alveolar nerve just before it enters the mandible. Okay. So right before it goes into the mandibular foramen, it gives off the nerve to the mylohyoid. You can find this nerve. Now, it's much smaller than the inferior alveolar nerve. It's a little twig of nerve, but it will be reliably there. Okay, so when you cut the mandible, try to protect these nerves knowing they're just on the other side. Okay, the next nerve we're going to talk about is the auriculotemporal nerve. The great news is you've already heard this nerve from every single other person that has talked to you about anatomy this week. So I'm not telling you anything new. And they've also mentioned to you that this branch of V3 will straddle the middle meningeal artery. And so I'm just reiterating something that was already mentioned. Really cool nerve, auriculotemporal nerve. We will find this nerve. It's also a pretty decent size, and it is going to come up and give sensation up here in the anterior aspect of the auricle, but it also has some branches that bring back sensation from the TMJ joint as well. And so the really cool thing about that is it will straddle the middle meningeal artery. I know I'm reviewing here. Now, I know you have also been introduced to the concept of presynaptic parasympathetic fibers that are going to reach their targets in a ganglion and then have postsynaptic fibers from these ganglion reach their destinations, right? So we have glands of lacrimation, we have glands of salivation. And I know that I remember that Dr. Nodcott talked about this course of cranial nerve 9 sending presynaptic fibers to the otic ganglion, and that those fibers, in his word, took an Uber ride with the auriculotemporal nerve to be able to reach the parotid gland. So I'm just reviewing. This is not new. I'm just reiterating something that we will see. You may not see an otic ganglion. You might remember he said it was about the size of a pinhead, very small, but we will see the auriculotemporal nerve. And you just know in your mind's eye that that gland that you just ripped out to find the facial nerve got its postsynaptic parasympathetic fibers from the otic ganglion. How many parasympathetic ganglion are there in the head? Does anyone know? 4. So we got the otic. Anybody? Ciliary. I know they've all been introduced. We got the otic, we got the ciliary, we have the pterygopalatine and the submandibular. There are only 4. So anytime anyone else says something about a ganglion, like Dr. Lawson just talked about a ganglion that was associated with the facial nerve in the ear called the geniculate, that's not a parasympathetic ganglion. What could that be? A sensory ganglion, like the dorsal root ganglion. All sensory ganglions are like those dorsal root ganglion that came from neural crest cells. Okay, so there's only 4. All right. And so ad nauseum, just to really drive this point home, remember, glossopharyngeal nerve will enter the middle ear and make a tympanic plexus. The tympanic plexus also receives sympathetics by this nearby carotid sympathetic plexus. So this autonomic plexus has both kinds of fibers in it. And then the lesser petrosal nerve will leave the middle ear. It will traverse the middle cranial fossa. It will go most of the time through foramen ovale. It will come down into the infratemporal fossa. Now we have the new stuff because you know now where the infratemporal fossa is. And it will synapse, comes down, synapse on the otic ganglion, and then hitches a ride, an Uber ride, to the parotid gland on the auricular temporal nerve. Now, all of us have told you the same story. We're all in agreement. All right, so let's move forward. The next nerves are pretty simple. One is called the buccal nerve. It does not innervate for muscle movement, the buccinator muscle, but rather it is a sensory nerve that brings sensation from the cheek area and the mucosal lining of the cheek. Okay, so the buccal nerve. How do you find the buccal nerve? Well, you'll find it because it will actually, when you course more superior and posteriorly, it will actually come between the two heads of the lateral pterygoid muscle, and actually says to do that in the dissector. So I just helped you out there. That's what I'm here for, I guess. So lingual, the lingual nerve is another nerve. You've already been introduced to the lingual nerve. The lingual nerve is headed to the tongue, okay? So that's cool about it. The lingual nerve receives fibers from the facial nerve called the chorda tympani, will come and join the lingual nerve and get another Uber ride on its way to the tongue. So the lingual nerve does the sensation from the anterior 2/3 of the tongue, but it also has these hitchhiker fibers from the facial nerve that is with it. And we'll go over this again because we have a ganglion that is reaching the submandibular. We also are receiving taste sensation from the anterior 2/3. Now, the lingual nerve is a decent sized nerve. It can be confused with the inferior alveolar nerve because, as you note, they're both coming approximately from the same area, and they're both kind of targeting and coursing in the same plane. But you're going to know the difference because the inferior alveolar nerve is going more laterally towards the mandible to enter the mandible, and the lingual nerve is going towards the tongue. So not only will it go more medial, but it also stays a little higher. And so those nerves end up like swinging one on top of each other. The lingual will be higher, and the one that's swinging lower, dipping down, is the inferior alveolar. Okay? And you'll get to see all this stuff. It'll make a lot more sense. All right. So this is where I just wanted to show you that image of how the buccal branch of V3 comes between the two heads of the lateral pterygoid muscle. And you can see the fibers lying on top of the buccinator muscle. So you could also go back from those fibers and go back up. But you should know that on top of these fibers is fascia and sometimes a buccal fat pad. And so if you're cleaning off the buccinator muscle, you can clean off these fibers. So now you know they're there, and you'll look for them and you'll save them, and then you can clean everything else off. Okay, so this was the osmosis slide here. And again, I know I'm not introducing this to you for the first time, but the chorda tympani is going to come out of the middle ear, does not traverse the middle cranial fossa, but it actually comes into the infratemporal fossa and joins the lingual nerve to its target destination. Taste fibers for the anterior 2/3 are actually running this way on the chorda tympani, and presynaptic parasympathetic fibers are coursing this way to reach the submandibular ganglion so that postsynaptic fibers can go to the sublingual and the submandibular glands. This is an image that just demonstrates what Dr. Lawson already introduced to you, and I think that Dr. Naucott also had a slide similar that shows you the chorda tympani running somewhat next to the tympanic membrane. Also note these arteries that are bringing arterial supply to the tympanic membrane, deep auricular and anterior tympanic. Those are two branches of the maxillary artery, and I have them listed on another slide later in this lecture, but I don't repeat the picture. Okay, so I just wanted to show you that that's where they go. And this image is really cool because not only does it cut away and show you the chorda tympani coursing, you can see the facial nerve in the temporal bone, chorda tympani coming off, but it shows you how it exits through the petrotympanic fissure, which you can find on the skull. So I would urge you to look for the petrotympanic fissure so you can see where the chorda tympani comes out and how it accesses the infratemporal fossa. Okay. Now, there are some nerves that literally just go to muscles. So masseteric nerves. You'll have to cut these nerves. You'll have to cut the nerves to reflect the muscle. You're like, oh, I cut off the zygomatic arch. I feel like everything's cool. Why is it not coming? Well, because it has blood vessels and nerves attached, and you'll have to cut them. When you do, say, oh, those are the masseteric nerve branches, please. And then to the temporalis, the same thing. When you reflect the temporalis, you'll see that there are some nerve branches called the deep temporal nerves that also bring innervation to the temporalis muscle. And you'll see those and have to cut those when you reflect some of them. Okay. A long time ago, one of my professors, Dr. Whitworth, he was known for making these elaborate slides with all the nerve branches as a study guide. I added this in here because it is sometimes helpful to have a nice diagram that just has everything in one place. So I wouldn't expect you to draw this out. But Dr. Nodcott also had some really nice figures and diagrams that are similar to this. And so I just wanted to include this so that you can sort of get the full picture. It also, on the dotted lines, shows you presynaptic parasympathetic fibers. And then you can see some postsynaptic, the green dotted lines that are on there as well. It also includes cranial nerve 9 and the lesser petrosal nerve coming over, synapsing on otic and hitching a ride on the auriculotemporal. So this is not, you don't have to draw this or anything. This is just for you to be included.
Dr. Ray?
Yes?
So if the facial nerve is like severed or paralyzed or something like that, you will not have your anterior salivation?
It depends on where in the facial nerve it is severed.
Okay, thank you.
So the facial nerve coming out of the stylomastoid foramen would not affect salivation, right?
Okay.
If you disrupt the chorda tympani in any place in its course, then before it reaches the submandibular ganglion, then yeah, you're going to affect salivation. Does that make sense?
Yes, thank you.
Okay. Okay, so that is really the coolest stuff because that stuff you're going to see, you're going to find, and I just think that we put it all together when we get to see stuff in lab. The pterygopalatine fossa is also really cool, and I have dissected it out from lots of different angles, but we are not going to dissect the pterygopalatine fossa. We're going to look at it with figures and images. You will get a chance to see this fossa when you look at imaging of the head. And it might help orient you to imaging when you're studying in your B&B course, or if you're looking at any imaging and you take the radiology course. And so it's included. All right. So where is this pterygopalatine fossa? Well, you can actually see it, and we were looking kind of at it in the other image. So if you tilt the skull a little bit, you can see that there is an opening here. This opening is called the pterygomaxillary fissure, and it allows you to peek into this space called the pterygopalatine fossa. You have two of them. You have one on each side. So this is the easiest way to see this space, and this red pipe cleaner is sitting in the pterygopalatine fossa. So we have this maxilla here. You can see the lateral pterygoid plate plays a role. The sphenoid bone plays a role, greater ring of the sphenoid bone. I'm going to show you a few other images. And then also the horizontal plate of the palatine bone, or called perpendicular plate, also plays a role. So we kind of get these borders, and you can see them in isolation, and you can see when you peer into your skull a hole, and you can see other holes inside, and yes, that's the area. And also look at the communication, the wide communication between this pterygopalatine fossa, this new space, with this infratemporal fossa region. So we're in very direct communication. So whenever you think of that, We're thinking about bleeding, we're thinking about infections, we're thinking about tumors. All right, so the sphenoid bone in isolation here, if you're wondering where the pterygopalatine fossa, I said the sphenoid plays a role. This is the foramen rotundum, and if you cut out this part of the sphenoid bone, just anterior to rotundum, you'd be looking down onto from the roof of the pterygopalatine fossa. And there's one on each side. So the foramen rotundum is a really great orientation point for this fossa. Okay, what is in this fossa? When I know I'm also not the first person to talk to you about this, and actually an image very similar to this was given to you by Dr. Anad Khan. So in this fossa, we have a ganglion called the pterygopalatine ganglion. It looks slightly different in each image. When I've dissected it out, it kind of looks like a V or pyramid to me. It just depends on the sheath that encloses the nerve structures. There are nerves that are leaving this ganglion. V2 is going to be on the roof. It's not really depicted that well here. You can see it right there. And then you see lots of branches. You see lots of arteries that are going with the branches. So all of these structures are there. And then what's not pictured but is there is veins. So also veins are all filling this space. Okay, so it's a small space with a lot of stuff inside. All right. And so this is sort of another figure that shows you the main point of this fossa is that it communicates with so many other spaces of the head. So all of these little nerves are going through foramen. So they have access to these spaces. So if you note here, or I'll just keep going and I have a cartoon drawing, okay? I know this is silly, but it helps. This is a complicated area. If you don't like it, just write it in my evaluations and I'll change it. But I think this might help. All right, so this is a cartoon drawing of this pterygopalatine fossa. So you can imagine, like the maxilla, you have the sphenoid, you have all of the borders, and you can put yourself in this fossa. Let's say I'm standing in pterygopalatine fossa, and I'm going to look laterally. So it doesn't matter what side I'm on, I look laterally, and I'm going to be looking through the pterygomaxillary fissure. So I liked this image I found online that shows you the pterygomaxillary fissure. Again, we are deep to the infratemporal fossa, and you can see the pterygopalatine ganglion inside. So in this pterygomaxillary fissure, we have the maxillary artery, which we haven't talked about, but we will, going through the fissure to give arterial branches to these foramen and to go along with the nerves. We also have some nerves coming out. So we have these posterior superior alveolar nerve branches that are coming out to help innervate the superior teeth. Okay, so those are the main structures that go through that fissure. If I were to look forward, I'm in the pterygopalatine fossa and I look forward, I would see the inferior orbital fissure. So here you can see that depicted here, the inferior orbital fissure. We found the inferior orbital nerve yesterday. Remember, that was the V2 part of the dissection. So we had the mental nerve V3 and we had the infraorbital nerve as V2. Also, the zygomatic branch also goes through this fissure, but that's a separate story. Okay, so that's cool. And we also have arteries that go through and vein. Now, if I looked medially in the fossa, I would have a foramen called the sphenopalatine foramen. And actually, if you look at your dry skull and you look into the pterygopalatine fossa with a little flashlight, you'll see a hole, and that hole is the sphenopalatine foramen. And that is how the nerve from the pterygopalatine ganglion gets access to the nasal cavity. And you'll have a whole nother lecture on the nasal cavity, and you'll see how that nerve branches out and innervates both the medial and lateral aspects. But the thing to note about this foramen is that the nerve is not the same name as the foramen, where that is the case in the other foramens. It's actually called the nasopalatine nerve. And that will just unravel itself beautifully when you see where it goes. But at this time, you're just like, oh man, it would have been really great if it was, yeah, I understand. But it is the sphenopalatine artery, which is the terminal aspect of the maxillary artery. So it kind of gives off branches, and then the last branch as it leaves, the termination of it is the sphenopalatine artery. Okay. Now, if I'm in the fossa and I look down, I have access to the oral cavity. I have some foramen that give me access to the oral cavity because we have these palatine canals, greater and usually lesser ones, that actually allow nerves and vessels to course inferiorly and go to the palate and in result have access to the oral cavity. Okay. And so when you do the oral cavity, again, these will be the players that come into the oral cavity to give innervation to this aspect of the palate. All right, and if I look backwards, I'm going to see that foramen rotundum. So if you could put a little camera through the foramen rotundum in your dry skull, you'd be able to look downwards and go forward and down, and you'd be right in that pterygopalatine fossa. And that makes sense because the V2 branch that goes through the foramen rotundum is going to suspend the ganglion. It's suspended from V2, all right? And so I put just to put in here a slide that would be the view if you looked back from being in the pterygopalatine fossa. This is what you'd be seeing here, and this would be rotundum. So that would be the largest foramen you would note. But then you note that there is another foramen that's a little bit medial to that. So that's what happens. There's another foramen, another hole that leads into the pterygopalatine fossa. And that's the pterygoid canal. And this isn't new, it also has been introduced to you that there is a nerve of the pterygoid canal that is coming to the pterygopalatine ganglion. And it gets there through this foramen. There are also vessels in this foramen. Okay. And then more medial to that, there is another canal. I'll use that word a little loosely because it doesn't look like necessarily an entire hole, but I did find this CT image from this study that does show you this canal, which is called the pharyngeal canal. It's also sometimes referred to as a palatovaginal canal. The pharyngeal nerve is transmitted through this canal to have access to the pharynx. So not only can we make it through the orbit, the nasal cavity, down into the oral cavity, we can also make it back into the nasopharynx region through this additional canal. And then if we went through the foramen rotundum, we would be in the middle cranial fossa. So then you see how anything, infections, bleeds, tumors, would have access to so many places if they were able to or originated from this pterygopalatine fossa. So what this image is showing you, the CT, here is the foramen rotundum. So this is sphenoid bone, foramen rotundum. This is the Vidian canal, which is the most used term clinically for the pterygoid canal. And then this is the pharyngeal canal here. So I took a dry skull and kind of showed you where the area of the pharyngeal canal would be so that you can look. Again, it's not like you might just see a elevated area. And this is another skull where I kind of busted through. It was already broken. I just made it more broken. And not here. I didn't do it to any of our skulls. And you can see the pterygoid canal and then the pharyngeal canal right next to it. Didn't know I had these highlights. Okay. All right. Again, the great news, this is not the first time. I'm just going to tell you this story one more time so you'll just know it by heart. The cranial nerve 7 gives off a branch called the greater petrosal nerve. Dr. Lawson just talked to you about this nerve. Remember, it leaves the facial nerve at the geniculate ganglion location and courses anteriorly. But there are no synapses in that geniculate ganglion. that nerve is still presynaptic parasympathetic fibers that are destined to synapse in the pterygopalatine ganglion. So the greater petrosal nerve courses anteriorly through the middle cranial fossa, and just after it courses over the foramen lacerum, not through it, it receives a branch called the deep petrosal nerve that comes off the sympathetic plexus around the internal carotid artery. Those two nerves together we call the nerve of the pterygoid canal. So we have both parasympathetic presynaptic fibers, and we have sympathetic fibers that have already synapsed together in a nerve. They reach the pterygopalatine ganglion, the presynaptic fibers that are parasympathetic synapse, and now we have postsynaptic fibers that leave the ganglion through all of the branches that we just talked about. So I know they only have a couple here that are shown, but it's really, oh, darn, I didn't realize I had to click. It's really like this. And what this is showing you here in this image is that here we have parasympathetic, we have sympathetic, nerve of the pterygoid canal, the ganglion. Now they're being distributed. So we have both parasympathetic and sympathetic fibers being distributed to all its targets. Oh, but these just have blue dots. How come they don't have any parasympathetic? Well, it's the skin. The skin doesn't have any parasympathetic needs. It only has sympathetic fibers that are reaching the skin to do the glands and blood vessels. Up here, we have skin. And I have all of the key for these figures included at the end of the lecture. And then this branch, this communicating branch between the zygomatic nerve and the lacrimal nerve, and if you remember that, that is how this lacrimal nerve receives the postsynaptic parasympathetic fibers that is needed to stimulate lacrimation that came from cranial nerve 7. Now you know why it's hooked up with that, okay? All right, hold on one second. I have to start the slideshow from current slide. Okay. All right, the maxillary artery. Dr. Tubbs, when he lectured to you, said, there are like 14 branches of the maxillary artery. And whoever lectures on that gets to decide which ones you need to know. So yay, it's me, and it's Friday. So I have divided up the maxillary artery, it's been divided. It's got 3 different parts, okay? And I'm gonna just simplify this. The first part of the maxillary artery, do you remember that the external carotid artery is going to terminate as the maxillary artery and go deep, and hey, now you know it goes into the infratemporal fossa, and then the other termination is the superficial temporal artery. This maxillary artery gives some branches right away, and these branches go into foramen. I showed you these two, and I said they innervate the tympanic membrane. So there are some that innervate tympanic membrane. The bolded ones you will find in lab. The inferior alveolar, I already mentioned to you, goes with the inferior alveolar nerve into the mandible. And then the middle meningeal artery is that famous artery that is going to go into the foramen spinosum that the auriculotemporal nerve wrapped around. Remember straddle? And so those you already kind of know too. So that's great. So we're going to simplify that. This is just to remind you of something that has already been introduced to you about the middle meningeal artery. And then in this picture showing you the middle meningeal artery going through spinosum, foramen spinosum, and the auriculotemporal nerve straddling. The second part are all muscular branches. Yay, you know the muscles. They have branches. They have, so that's okay. That really helps, right? Temporalis branches, we have branches of the masseter muscle, we have branches to the pterygoid muscle. So we can simplify this. There's also a buccal artery. I understand the nerve doesn't innervate the muscle, but the artery does. So that's great. We're going to simplify that. And the great news is that these last branches are the ones I just talked about because they're in the pterygopalatine fossa and they're going through those foramen. So they're really not going to be new things either. I'm just sort of reminding you about these characters that you've been introduced to and tell you again why they're important in a slightly different way. So you can think about the foramen and which nerve goes through and which artery, or you could think about the maxillary artery course, or you could do it both ways. But the good news is that we're just going to simplify the maxillary artery into 3 parts. We have a couple important ones that go through foramen. We have a bunch of muscular branches, and then we have those that go through the foramen that are from the pterygopalatine fossa. Deal? All right. Okay, so this is a simplified slide from osmosis that shows you the different nerves and arteries that go through each of the foramen from the pterygopalatine fossa. And then both Dr. Nodcott and Dr. Tubbs introduced to you this concept, and it is a very important clinical concept about the pterygoid venous plexus. You will see this venous plexus, all of these veins that will be in your way. You'll probably remove many of them so that you can get to the nerves and arteries. And this is the clinical highlights about how this pterygoid venous plexus has a couple different routes. It can get into the orbit by the inferior ophthalmic vein, okay, and spread bleeding, infection, which Dr. Tubbs mentioned several times causes clots. And then you can see how the deep facial vein has communication with this pterygoid plexus. And so if you have any kind of infected wound or other parts of skin and hair follicles that might be infected, that you can have some retrograde flow and it can get up into the orbit. But it also, there are some emissary veins that allow the infection to go directly to the cavernous sinus. And so this is just to reiterate that. I do have some slides that show you, because of time, for me to list all of just V2. So V2 is more, not a whole lot more, but it is a little more than just the pterygopalatine branches. And Dr. Nodcott promised you that he would summarize V2 and V3 and V1 next week. And I just put a study guide in here. You can click along with each branch, and I have little descriptions about what all of the branches are and where they're going to, if you want to do this. This is not necessary, but it can be just maybe fun, or it depends on, I guess, how you define fun. So give it a shot if you want to. If not, feel free to ignore. Okay. Was. All right. Sorry about that. There, I have a hyperlink in the show that will allow you to go back and forth. The temporomandibular joint. Most of these details have already been introduced to you. That's why I put it last, because last year I did the pterygopalatine fossa last, and I was like, that was probably not the best idea. So we're going to switch it up. We're going to do TMJ joint last. All right, so when you have your skull and you have the mandible and then you have the rest of the cranium, you have probably just not even thought about it and put them together multiple times, and so that you can study and carry them around. But if you take it out again, pay attention to the area that is smooth of the temporal bone. That's called the mandibular fossa. And you can note that it is going to be the place where this condyloid process of the mandible is going to rest in this mandibular fossa. There will also be a protrusion just anteriorly called the articular tubercle, which is important because it stops the condyloid process of the mandible from jutting out anteriorly, unless there's more force than normal. And then also this spine of the sphenoid bone, there's a small little spine. It's not this styloid process, but it's a little protrusion here. That is where one of the ligaments that helps stabilize the mandible originates from, the sphenomandibular ligament. And that is the ligament, the larger ligament that you're going to see in the mandible when you have to go through the infratemporal fossa. Well, this is where it starts. Okay, so it is a modified hinge joint. So it does have some gliding motions and some rotation. So your jaw does not just go up and down, up and down. You can move your jaw from side to side. and you can glide your jaw forward and back. And so here you can see the different, we have elevation and depression used instead of just flexion and extension. They both be correct, but we, most of the time when talking about the jaw, would use elevation and depression. And we talked about the muscles already that act upon this joint. Okay, so you can go back to those slides and, oh yeah, the temporalis, and don't forget that lateral pterygoid is the only one that helps with depression. Okay. And we did already talk about the arteries that supply blood, because those are the arteries that are branches of the maxillary artery. And there are two nerves that help with bringing sensation from this joint. And we talked about those, the auriculotemporal nerve and also the masseteric nerves will help bring sensation from the TMJ joint. Now, the cool thing about this joint is that it has an articular disc between the two surfaces of bone that are making a joint. And what that does is separate this joint cavity into kind of two different joints. So we end up with a superior articular cavity and an inferior articular cavity because of this articular disc. And we have different motions that are involved in the different aspects of this joint. So the superior articular cavity will allow the mandible to glide. And when you put it in there, you can kind of, even though the disc isn't there, you can kind of pretend like you're doing those actions. And so you have protrusion and retrusion that will occur in the superior cavity. And the inferior articular cavity is simply the hinge joint movements of the joint. Okay, so that's as simple as we can make the TMJ joint in regards to its motions. The joint has a big capsule, has a nice capsule, and that helps with stability because you certainly, you know, your jaw goes through a significant amount of motion, and also you hit your jaw on things, you sleep, you have your head on the pillow, so you're constantly putting stresses on your jaw. You have a nice thick joint capsule, and there is an intrinsic ligament that is called the lateral ligament that helps stabilize the jaw, the TMJ joint. And then you have two extrinsic ligaments that also aid in stabilization. The lateral ligament is really a thickening of the joint capsule, but it is very important, and it prevents the mandible from dislocating posteriorly and gives a lot of strength to the joint, as you would imagine, laterally. So if I was laying on with my head on my pillow, and I do have a lot of TMJ pain, I can feel, you know, the stress that it puts on my left TMJ joint, and I would be stressing this lateral ligament. And then the other two ligaments we have actually also introduced you to, that sphenomandibular ligament that comes from that spine of the sphenoid, comes down to the medial aspect of the mandible, really in the area of the lingula. That is a very important stabilizing ligament, especially during hinge movements. That sphenomandibular ligament plays a good role. The stylomandibular ligament that originates from the styloid process plays a more minor role, a very minor role in stabilizing the joint. So it really just contributes a little bit. And then the clinical application, a clinical application that's important for the TMJ joint, is I wanted to point out, when you look at the mandibular fossa, put your finger, you know, on both sides, from the inside and the outside, and see how very, very thin. Or you can hold the skull up to a light. You'll be able to see kind of the brightness of the light behind in that area because that mandibular fossa is so thin. So if someone was to really have a blunt trauma to their mandible, that condyloid process could go through the mandibular fossa, and it would be in the middle cranial fossa. So that is, you don't want that to happen. Darn it, look at me, 1 minute to spare. All right, I know that was a redonkulous amount of information to go through. I was just given this task. I did it. I'm happy. I am more than happy to answer all of the multitude of questions that you have for me via email, you know, text, Zoom, whatever you have. Hope you find the extra questions and the study guides that I gave you at the end helpful. And have a good rest of your Friday. I know you have one more thing to get through, and hopefully it's not as dense as this one was. All right.
Dr. Ray, I have a really
Yes.
quick question.
Yes.
Is there two buccal nerves, one coming off of the facial nerve and then the other off of the maxillary nerve?
Yes, the buccal branch of the facial nerve is the motor innervation to the buccinator muscle. And the buccal branch of V3, which is sometimes referred to as the long buccal, just so that it doesn't get confused, but they don't have that in your textbook. That is a sensory nerve that is only bringing sensation from the cheek and sensation from the inner mucosa of the oral cavity.
Thank you.
Sure, absolutely.